I think one of the key issues here to consider, and this is an outline where I'm going to go over how do we compare risks. We'll look at risk communication in what I've called the ecosystem, and that's a point that I think Sid and Supriya certainly made already. We'll look at how behavior change theories can help us evaluate the effectiveness, and I really want to say a little bit about vaccine communication. There was an excellent piece posted just a few days ago on BBC Media Action that I thought gave us some really valuable pointers in terms of vaccine communication. So here's just a question to think about, okay? We all face people, regions, countries, all face all sorts of risks, all sorts of emergencies. And I've worked quite a bit in South Asia, most recently in Bangladesh, which gets flooded every year, gets cyclones. And, people know what to do, and governments know what to do when they get a cyclone, or when, in Assam you get flooding from the Brahmaputra. We know there's going to be people displaced. We know there are going to be waterborne diseases. People are familiar with the risks and how to approach them. So we're well rehearsed, I think, at trying to deal. We don't always deal with it successfully, but we kind of know what to do when faced with other diseases, cholera, malaria, for example. So why do people take precautions about safe drinking water and mosquito control? But when it comes to the virus COVID-19, many people have not adopted the kind of behaviors we expect them to adopt. So, I think that's kind of one question for this whole webinar. Why do we view some risks differently from others? What we should have in here is something called a social ecological model. And I think every speaker so far has sort of talked about this, but this is sometimes described as an onion, where we need to consider how communication functions at different levels. So we have individual communication, we have interpersonal communication, and then we have groups and organizations we communicate with. So we recognize that there are communication works in different ways and different levels, and that people in their responses and their behavior are open to communication at different levels, from family members, from friends and people in their community, from their religious organizations, from government health workers, from media. And so we need to recognize there are multiple communication approaches that can be taken. And this comes back really to the point that Sid was making about evidence-based research. We need to figure out, and it is contextual, it is local, which sources of communication people trust. Governments like to believe that government workers are trusted. I think there was one slide in there on the research that was done in Sid's presentation, which sort of indicated that government health workers did have a reasonable amount of trust, but that's not the same everywhere. Okay, in some areas, governments are distrusted. So we need to figure out who the influencers are, who the most important sources of communication are, which media people use, which people. There's been a lot of research on this, but it is fairly typical for governments and scientific experts, including public health experts, to think that expert communication is what works. Okay, you provide the scientific data, and people will go, "Oh, that's right, I'm going to do that." Well, I think we kind of agreed. I mean, it's been said we've got to listen. Listening is so important. We need participatory approaches because experts and government agencies are not always trusted. Now, and I want to kind of make the broader point there that it's not just about health. If you don't trust the government on taxes, if you do not trust the government on how it spends its money, if you don't trust the government on environmental protection, you're probably not going to trust the government on health. So, it's not as if, we trust government health experts and don't trust other government experts. Somebody from the government, somebody from an official agency may simply be distrusted because they're from the government. So that's a big challenge, I think, in public health. So we know also, as I said, that people get their information from many sources, the infodemic. So very difficult to keep messages consistent when there's so many conflicting messages coming through, and rumors and disinformation. Okay, so these are just some of the goals of risk communication, which I think we've pretty much gone over, and social, religious, cultural, political, economic aspects of risk need to be considered. And this is sometimes, I think, where the public health experts get it wrong, because they're talking simply about the health part of it. And I think, we've seen in many countries, including the United States and certainly in India, that, there's an economic balance that's being drawn. That's why, people are making decisions. I do remember reading when COVID-19 started really spreading in India, day laborers were stranded in their cities. They were not able to move, and people said, I'm going to die of hunger before I die of COVID-19. And so I think that point is really important. It's not just a health issue. It has to be considered in this broader. We're talking here about the type of risk, and I think this is a fairly useful way to start thinking about it. Okay, so and I'm sure some of these questions are in some of the research that UNICEF and WHO are doing. Is the risk something new? Is it unfamiliar? Is it something that can be seen or sensed? You see the flooding happening, you see the cyclone coming in, but you don't necessarily see, you can't see the virus spreading. Are the risks from a vaccination campaign? People think about, will it affect future generations? I'm thinking back to, I forget who made the comment here, but how in the culture, people say, I want my children to be vaccinated. Well, that's a concern about a future generation, but in fact, that may be the wrong approach, because it's older people who are most in danger there. Is the risk going to be catastrophic? Is there unequal harm posed by this disease or this emergency? And this comes back to, I think, the Vice Chancellor was saying there, are specific groups in society affected? And I'll come later to a comment from a colleague in South Africa who, in response to an article, said, well, it's all very well to have, all of these cautions that we should be taking in terms of social distancing and hand washing and all of that. But, if you don't have water, if people are living in poverty, the kinds of behavior that are possible in a more affluent society, or certainly middle income country, are certainly not possible there. So I guess I'd like you to think, as we go through this webinar, which of these kind of factors apply to COVID-19, and again, how we assess the risk of COVID-19 versus the other much more familiar diseases such as cholera or malaria. Well, I'm an academic, so I'm going to have to throw in some theory here, okay? And I simply rely on this great quote from the social psychologist Kurt Lewin: "There's nothing as practical as a good theory, and the best way to understand something is to try to change it." Sid was pointing out earlier, the need for evidence-based interventions. And I would say absolutely agreed there. And we also need to have some understanding of human behavior, individual and collective, and why people may or may not change their behaviors. And for that, we need some theory. And so, let's just go through very quickly 3 theories here that I think may be applicable. I mean, there are literally hundreds of health communication theories, and I'm not trying to privilege any particular ones here, but I think that when we think about how we design communication interventions, we do have to have them informed by theory. This is a health belief model. I think it's pretty straightforward. This is the way in which people weigh their behaviors, weigh the risks they're gonna be taking. Do I believe I'm going to get COVID-19? Perceived susceptibility. I think what we've seen with a lot of young people is, they believe they may get it, but the severity of it, the second column here, they don't believe they're going to die from it. Well, certainly young people have died. What are the benefits of the advised action? Social distancing, mask wearing, hand washing. What are the barriers? Again, coming back to the point my colleague was making in South Africa, if you don't have ample water or clean water, then hand washing is quite a challenge. Cues to action and self-efficacy, confidence in one's ability to take action. So I think the health belief model, this is kind of an interesting way to sort of think about the way people may approach the changes in behavior that we are asking them to take in response to COVID-19. All right, this is familiar to quite a few people here. I could have a lot of fun with this one. Yeah, so where does Donald Trump appear on this one? He would certainly be in the laggard category. So, this is the Everett Rogers standard diffusion curve showing how a new practice, and in this case, we could be talking about mask wearing or social distancing or hand washing, how that diffuses through a group or a community. And so we have, the innovators, probably the health professionals who are adopting this, and then early adopters, then early majority, late majority. I would say the standard diffusion curve looks quite a bit different in some countries from others, and I'll be really interested to see as the research comes through how this is plotted. And we may also be able to look at this and kind of from a socioeconomic standard in terms of education levels and things like that. But the point being here is that a new practice is adopted. Now, this is a big problem in an emergency. In an emergency, you need a lot of people, to take the new innovation or the practice, hand washing, social distancing, mask wearing, very seriously, very quickly. So you really need that curve to be really big at the beginning. Okay. That, I think, has happened in some countries, certainly not in the United States. And so think about that. And these are some of the tests that people will apply in deciding whether to adopt a new practice. Its relative advantage, its compatibility, how difficult it is to do, can we test it and experiment it, and does it produce tangible results? I think these are interesting categories, and I think, the research is still out on the degree to which this will apply to COVID-19 as we're kind of moving up in terms of level. And this is agenda setting theory, and this really shows how the interplay between gatekeepers and media, public policy, and people's actions. So what there's this kind of circular movement between the media agenda, the public agenda, and the policy agenda. So the notion here is that when something becomes important enough in the media, it gets a lot of media coverage, then it becomes important in the public agenda, and then eventually in the policy agenda, then eventually the policymakers start doing it. Again, this is somewhat complicated. I mean, it's not a simple equation here, because we have personal experience and other communication influences which are conditioning how we view things there. So I would say that in the case of COVID-19, agenda setting is certainly important, but it has not been even. There's been a lot of effort here to get positive media coverage, but there's also negative media coverage, and the public agenda has been somewhat confused, and certainly in some countries the policy agenda has become confused. So those countries which have been successful, I think, have had good government policy, which is supported by the public and supported by the media, but that certainly has not happened. Right. I wanted to draw this distinction here. I mean, we talk about communication for development, but I think we need, in the case of COVID-19, and indeed in other areas, to break things down a little bit. There are different categories of behavior. There are what I would call specific or time-bound decisions and actions. Things you do once, or in the case of vaccinations, twice. So, I've been tested 3 times, negative every time. I'll probably be tested again. I will get vaccinated. It'll be twice. So these are very, very specific things. Today, I'm going to go and get a test, okay? Or today, whenever it happens, I'll be vaccinated. Now, but the more difficult thing are the behaviors that have to go on all the time on a consistent basis. The mask wearing, social distancing, hand washing, avoiding gatherings. Those are things that have to become part of daily life. They have to become almost social norms, things that people will do without thinking about it. Okay, and it's been, I'll just share a very interesting sort of conversation with you here. It's very interesting to visit supermarkets in the United States. If you see somebody in there who's not wearing a mask, people will start shouting at them. Okay, yeah, because this has now become unacceptable behavior. A few months ago, people went, oh, well, it's your choice. Now I go into a supermarket and somebody's not wearing a mask. Well, firstly, they may not be let in the first place. But if they take off their mask in the supermarket, people will get quite angry with them. So I think we're perhaps moving towards mask wearing as a social norm rather late, with 3,000 people a day dying in the United States. Anyway, the point being here that we may need a different strategy to address vaccination or testing from one which addresses mask wearing and social distancing, because these are different types of decision or action. Okay, I wanted to kind of conclude here with just some, if we'd been doing this webinar a month ago, before, when vaccines were on the horizon but none had been improved, then it might be premature to talk about it. But I think we really now need to think very, very carefully about vaccine communication and how the vaccine communication programs are going to differ from those on testing and those on social distancing and mask wearing. And just a couple of points here. First, people have made the point, there's a difference between a vaccine and vaccination. The vaccine has to get into people, shots in the arm. So these are really the three essential elements, and I would defer to Supriya as the public health expert, because I'm certainly not, to build on this. We need to have an adequate supply of vaccine, and it has to be either free or very low cost. If you make it too expensive, then you're going to exclude a lot of people. And it has to be accessible. You don't have to travel for 2 days and lose work and money in order to be able to get that vaccine. And thirdly, and this is the communication part, we have to believe that the vaccine will work, it will be effective, will not have serious side effects. And so communication is really, really important to help build trust. But at the same time, even if we convince everybody that the vaccine is good and then it's not available, then the communication will be distrusted. So these kind of parts of the equation, I guess we call them all parts of the supply chain, really have to come together. Adequate supply, accessibility, and trust. And then the point at the bottom, which is one I started thinking about, and I have no clue how to answer, but maybe Supriya or Sid will have some thoughts on this. If you have more than one vaccine available, do you have a choice? How do you compare one vaccine with another? You're not a scientist. So I think that's going to be a kind of interesting one in some countries where, there may be one of the European, North American vaccines available. There may be a Chinese vaccine available, maybe a Russian one. Well, maybe the Chinese one's cheapest. Do I go for that? Some really kind of difficult and interesting, I think, questions. So the other day I came across, just in my email, some comments on a new article or a blog post, and I really wanted to share this with you, and you can look it up. It's easy to find. It's by Yvonne McPherson from BBC Media Action. And the article, which was also reposted on the Communication Initiative, is called 5 Mantras for COVID-19 Vaccine Communication. Now, I've got a bit of a problem with the word mantra, because I know that has a much deeper religious significance in Hinduism and Buddhism. And, in the West, the word mantra is kind of widely used for something. Maybe it should be just 5 guidelines for COVID-19 vaccine communication. Why it's a mantra with all of that added meaning, I'm not sure, but that's right. Okay, so get a hell of a chance. We can't wait. We need to act now. So they point out, McPherson points out that some people are saying, oh, well, before we do vaccine communication, we just have to get the supply chain in order and make sure all of those things are working, that, we have an adequate supply and it's available, and we have staff that are that have the, the skills and the equipment to administer the vaccine, etc. And, she argues, I think very convincingly, that, that may be the scientific approach, but, the way people react, people are thinking now, am I going to get the vaccine or not? When will I get it? People are already forming their opinions. And we also know that there are groups that are likely to resist vaccine. The latest public opinion polling I've seen in the United States indicates that around 40% of people right now say they're not going to get a vaccine, which is quite scary in a way. Now, maybe that needs to change. So we can't wait for the vaccines to be there. We have to begin vaccine communication now, or should have started it already. The science is going to need some art and craft. Okay, we kind of made this point already. We need data, but people generally don't absorb scientific data very well. we need to look at the local, the cultural context. We need to look at people's religious beliefs, and we need to respond to people's real fears. And we need to do this with narratives, and again, I think Supriya and Sid made this point, that focus on dialogue, that are participatory, not top-down preaching narrative. Again, I was making some of the same points here, that while I think we can gather evidence and, come up with, some principles for communication strategy, global campaigns, are probably not going to work. We need different strategies for different communities. I think this has been made very clear several times so far, so I'm not going to stay on that one. Here we are. Okay, my little graphic did pop up again. This is a social ecological model, and we simply need to recognize here that that people do not get information on anything, certainly not on health, from a single source. They may get it from family, from community, from organizations and government workers, religious leaders, and then there's this kind of policy and media framework about it. So we need different strategies. And also, we can't have the same strategy for the same audience. I mean, health workers need to know something different and different behaviors from other groups. So the way in which we approach religious and community makers, or the way in which we approach journalists and editorial decision makers is going to be different from the way in which we approach other groups. So different communication strategies for different groups, and I say also very much needs to be localized and contextualized. I thought this was a really interesting point that Macpherson made. I'm just going to, we know it's going to be a long-term campaign, but the point at the end, the vaccine is going to be available to different segments of the population at different times. And so right now, the communication needs to be with, probably the two target groups, the primary groups, are going to be health workers. And, there are health workers who say they're not going to get the vaccine. Okay, that's concerning. So, there needs to be a communication intervention that's going to target health workers. And then there needs to be a communication campaign that targets people in, what shall I call it, my demographic, okay? Older people who are more at risk, who may have pre-existing conditions. So I'm not saying we leave young people out of this here, we leave social media out of it, but that will come at a certain time. Right now, because we know certain, or we expect certain segments of the population to get the vaccine at, earlier rather than later, that's really where our efforts should be focused. So the communication interventions and the strategies are going to have to change over time as the vaccine becomes available to different groups. So I referred to this earlier. Sue Goldstein from Seoul City, a well-known, well-renowned communication for development organization in Johannesburg. Lovely person, by the way. So she's commenting on this post by Yvonne Macpherson on the 5 mantras. And I mean, she makes this real point, and this comes back to what Dr. Jean was saying about vulnerable communities. If people don't have running water, or they don't have money to buy masks, or even food, infection control is a lot more difficult. So we need to consider, it's the equity question that Sid was talking about, we need to consider what we need to do there. So Telling people what to do if they don't have the means to do it is not effective communication. And I love this quote. Sending messages to people in a scientific way or trying to scare the boots off them just doesn't work. So fear messages are likely not going to work here. And then she ends by saying, look at one of the most sophisticated countries in the world where the virus is spreading like wildfire. Throwing messages doesn't seem to